in and difficult situation. I would like to invite our convener Dr. Anurag Mishra and chairperson Dr. Arup Chakrabarti on the dais, please. Our first speaker is Dr. Pradeep Kumar Mohanta sir. I think he will be speaking on a device. I think himself discovered this device that. So can we have the slides, please?
Hooks are necessary. For example, in a case and the iris is pulled anteriorly. Behex, the iris remains at its own plane. No extra step wounds is necessary. It can be managed with only one side port. But in some cases, iris hooks are necessary. For example, in a case like this, where the pupil is very small, iris hooks may be a better option. Though we can use Behex in such cases also by removing the membrane around the pupillary border and doing controlled stretch of the pupil. However, iris hooks is a better option in such cases. We must use the trypan blue dye underneath the iris so that the anterior capsule is stained all around. Such cases may have a very hard nucleus. In this case, I am making 4 stab incisions initially, like 1 o'clock and 7 o'clock, and then 10 o'clock, 9 o'clock, and this is at 4 o'clock. And now I place the iris hook at 7 o'clock, maybe 6:30 o'clock, and then the next on. Now see how to place the iris hooks. The silicone guard is pulled backward and then the iris is hooked, the pupillary border is hooked, and the silicone guard is advanced. This is the third hook. The main incision is at around 11 o'clock and this hook is at around 2 o'clock. One more hook at 4 o'clock. Now as we pull the iris hooks, the pupil takes this shape. And I need some more exposure. So I make another small side port at around 2 o'clock and place on more iris hooks. And now capsulorhexis is done and the nucleus is nicely managed. And then the bag is filled up with visco and the intraocular lens is placed in the capsular bag. Before injecting the intraocular lens, one hook is removed so that the iris is not stressed too much by the leading haptic. After placing the lens in the capsular bag and some visco, the hooks are removed, the silicone guard is retracted backward, the pupillary margin is unhooked, and the iris retractor is pulled out. So this is the use of iris hooks. And now see the use of BHEX. In this case, only one side port has been made. And this is the hexagonal device invented by Dr. Suben Bhattacharjee of Kolkata, India. Alternate flanges are tucked under the iris. One flange has been tucked at 7 o'clock, another on at 3 o'clock, and this is the on which is tucked at around 10 o'clock. And now the nucleus is managed. In this case, it was a hypermature Morgagnian cataract, and IOL scaffold was done for a removal of the last piece. After nucleus management, all the visco and cortical matter is removed, and then the BHEX is removed in this way. One of the flanges, that is above the iris, is pulled centrally, and then it goes peripherally, and all the flanges are untucked, and it is just pulled out. Thank you very much for your attention. To use iris hooks, we have to make 4 to 5 stand wounds, and the iris is pulled anterior.
Thank you, sir, for that wonderful lecture. Since we are running a little bit short on time, so we'll take questions in the end of the session. I would like to invite our next speaker, Dr. Amit Porwal. Sir will be, if sir is there. Okay. No, no.
Good afternoon. I thank the organizers for giving the opportunity and share my experience of femto for the last 5-6 years. Next. Right. Femto, the principle for the beginners is similar to that of a YAG laser, photo disruption, but the duration of the pulse is much shorter. This femto consisting of both phaco and femto. In this advantage of the femto procedure of the femto is the docking is extra. The docking is with patient interface, which is attached to the eye of the patient and the machine, and you can plan the treatment, treat the following way. This is a case of posterior polar cataract where the entire lens is softened, which is aspirated. The phaco energy is much lesser. At the same time, the posterior capsule is 500 to 600 microns away from the procedure. It will act as a cushion. Here the phaco energy used is just 2.8 CD. The role of femto is capsulotomies, lens fragmentation, corneal incisions, and arcuate incisions to manage the astigmatism. So the capsulotomy is more central, accurate, and better IOL centration. So these are the parameters which you can adjust in the mission. For us to understand, it took 3 years. So is the case of hypermature cataract, on the left side is a phacosurgeon, on the right side is a femtosurgeon, where the right side you can do this capsulotomy within a fraction of the second, which is accurate, and you are definite about the rexis, whereas in the regular manual method, sometimes it may run away. So as far as the dissection is concerned, it causes a pneumodissection where the air bubbles separate the lens and the dissection is very much easy with the femto. You can see the easy rotation, same time the 500 microns of this cushion is there. The best method of the part of this femto is online visualization of the lens, where on the left side you see a thicker lens, on the right side is a very thin lens. Normally when you attempt the phaco, you don't know the thickness, sometimes inadvertently you may reach the posterior capsule causing the runs. So in a case of hard cataract, the femto gives the 8 fragments which you can repeat 3 times, 4 times, so that it gets separated. Once it gets separated, our job becomes easy. This fracture is as that of a Cadbury chocolate, and you can eat these fragments. The phaco energy is reduced more than 50% of the times. So this is a case of posterior polar cataract. You are afraid to operate on these cataracts because of the incidence of the PCR is more when compared to the normal cases, and also these patients are very young patients. So if you do the femto and adjust the parameters, the incidence of PCR is much lesser. In this particular case, patient opted a multifocal lens. So in a white cataract, what is the teaching is the waste of doing femto in a white cataract. This is an example where a fully white cataract, you get a clear cut rexis with a 5 mm, and you see even the nucleus is divided into 8 fragments, even though it is a white cataract, which reduces the phaco energy and saves the endothelium. These are the parameters available to adjust the fragmentation. Similar to that of phaco, it takes long time to understand the parameters. So in a case of pediatric cataract, the important step is capsulotomy. This capsulotomy can done, but it is not approved up to now. But I tried some of the cases. It gives both anterior and posterior capsulotomy, but the size of the capsulotomy, you should be careful. So in a pediatric cataract, if at all you want to operate, it requires a larger OT which accommodates both the mission as well as the phaco in the same. This is my setting, my theater, and they require smaller patient interface which are available with Catalase. So these are, I did around 30 eyes in a pediatric cataracts. The results are excellent. So I am following this for some more years. So this is a case of a fibrotic capsule. By adjusting the energy parameters, you can even cut the fibrotic capsule, which is difficult in a regular rexis with cystitome. So the other cases where I like to introduce this is PPC, black cataracts, subluxated cataracts. So this is a case where there is a suction loss during the procedure. You need not worry about it. You can redock it and enlarge the previous rexis size. If it is a 5 mm previously, you can go to 5.5 mm and do the procedure and you can complete. Similarly, you can repeat the lens fragmentation. This is one of the doctor, 85 years, with a black cataract. He wants cataract by any means, laser by any means. His neck rigidity is there, for which I could manage this by lifting the foot end of the foot end of the patient and completed the surgery. So the future applications of this femto is pediatric cataracts, posterior capsulotomy. It will alter the refractive power of the IOLs. If at all there is a refractive surprises, you can apply this and alter the refractive power of the intraocular lens. You can divide the intraocular lenses, ICLs, and the phimotic capsules, where you can easily take out the fragments of the lenses. So this is the thesis given to one of my postgraduate in pre-corona period. He did for 200 cases. These are the results, but the results are still better after corona. So if at all you want to introduce this step by step, you can introduce in our practice. First the rhexis, afterwards fragments, afterwards the corneal incisions. To conclude, it is an extra ornamentarium in our setup. Safety margin is high. Posterior capsule is 500 microns away from your work. Rhexis is regular, no intra or postoperative complications. There is a minimal endothelial loss. There is no striate keratopathy. Believe me or not, even one line of stria postoperatively, a patient is unhappy in the first day. He will be happy only after 2-3 weeks. So no stria will be there in these cases. Safe to incorporate in our surgical setup. So very useful in some of the special conditions. Especially I am working on pediatric cataracts. Only hindrance is the cost. Thank you.
Thank you. Thank you, Dr. Reddy, for the wonderful presentation and
Thank you, sir.
Multiple uses of femto laser now, because it's coming up and more cases are being done with the femto laser. Thank you very much.
Thank you.
And our next speaker is, yes. Yeah. Okay. We'll take up the questions later after we finish all the speakers, okay? So our next speaker is Dr. Prafulla Maharana, and Dr. Prafulla is from AIMS Delhi. He's the professor over there. And he's going to talk on phacoemulsification in corneal ectasia.
Good afternoon all. So I'll be discussing the surgical challenges that somebody encounters while doing cataract in a corneal ectasia, or more specifically keratoconus patient. So what are the challenges that you have in such patients? The most important is biometry. Remember, in keratoconus, the relationship between your intercorneal power and posterior corneal power is changed. The cornea is bulging. So if you use an axial length measurement method that depends on contact method, again you will get a wrong estimation. So the preferred method of biometry in such patients is IL master or any optical biometer. Now, which is the best formula? So there is a lot of debate, but recent literature suggests Kane keratoconus formula is probably the best one. This is an article from American Academy of Ophthalmology. If you look here, the least error or the least residual error was with modified Kane's keratoconus formula, which was 0.8, then SRKT, then Barrett's Universal 2, then unmodified Kane, then Holiday 1, then Holiday 2, and Hygis and Hofer-Q come subsequently. So this is probably, as per the current literature, best formula to use. Now I'll go through a video to discuss the other important points that you should remember in keratoconus and cataract. So limbal entries. Why? Because cornea is thin. If you make a clear corneal entry, then that may not be self-sealing, and you may have to put sutures. So that is one. And second, when corneal wound heals, it may induce some astigmatism itself. So it's always better to go for limbal incision. Staining the capsule is must in all such patients, because although the cornea appears clear, but there will be a lot of distortion when you are taking your instruments in, and that I'll just show you in one of the subsequent steps. As you can see here, the rhexis is attempted, but when the rhexis forceps comes here, you will find there is a distortion. Okay, so that time if you haven't stained, then it may be difficult. So from when you are taking the your instrument in the cone area, then there will be distortion. So to take care of that, you must use the rhexis forceps and don't leave the flap at any point of time, and stain the capsule. Then rest of the steps are similar to phacoemulsification, but one thing to remember is, there may be some difficulty in depth perception. You may be feeling that my PC is quite behind. On the contrary, it may be very anterior, and you may land up in rent if you are not careful, because the cornea is irregular, and depth perception, stereopsis, both are affected when you are operating using the microscope. And this is conjunctival ballooning. If you do a limbal incision, this is bound to happen in most of the cases, but nothing to worry, just give few relaxing tenotomy incision, that will be taken care of that. And the bag size is usually big in such patients, है ना? And so the nucleus pieces may not come easily to the phaco handpiece. So what you can do is you can inject some viscoelastic and bring those pieces near your near the center, and then you can complete your phacoemulsification. And another important thing that you should remember is in such cases there may be hidden pieces. Pieces may go into sulcus, or it may be in the angle, and when you feel that your surgery is complete, then somewhat suddenly one piece may come. So do a meticulous IA and do it for little bit longer time compared to your routine phacoemulsification. So these are the few practical tips one should remember while using this. And personally I would always prefer to put a suture. However, if you feel that your wound is healed, it's self-closing, then you may not, it may not be required at all. So this is a case of keratoconus with PMCD, with hydrops, with little bit corneal scar. The surgical procedure is similar to the previous video, but except one thing, remember always try to avoid the scarred area. Don't make your incision through the scarred area. And even if you are making the incision, it should be perpendicular to that. If you make incision along that, the study suggests it may induce more astigmatism. If you have a microscope integrated OCT, that may help you little bit, but it's not mandatory. Even you can do it without that. Rest of the steps are similar to the previous case. Stain the capsule, use your access forceps, be careful about distortion of your instruments, and be careful about the depth perception. It may not be exactly what you are thinking. So this is a paper which me and Dr. Namta have published about phacoemulsification coexisting corneal opacity. You can go through that. It has all the practical tips for doing that. So just to summarize, what are the difficulties that you may encounter in corneal ectasia? The most important problem is probably visualization. Why? Because there will be light scattering, there is difficult depth perception, there may be corneal scar, and the cornea cone junction may cause a lot of difficulty. So how to bypass that? Use trypan glue, use viscoelastic, that improves your contrast little bit. The second problem is when to where to put your incision. I have already told that. Always try to avoid the scar area, go for limbal or corneoscleral tunnel. And if you feel that the incision is not self-sealing, always put a suture. So this is a paper by OE et al. Where they use RGP lenses. If you see the first picture, without RGP there was distortion, but the moment you put an RGP lens, it becomes more focused. So this can also be used while doing surgery. This is a Jarrett protocol, which suggests how to approach cataract in keratoconus patient. Remember, first ensure if the if the keratoconus is stable. If it is stable, go for a toric IOL. If there is regular astigmatism, if it is not there, go for a monofocal IOL. If it is not stable, you can use all the methods like CXL with Intax to achieve a stable keratometry. Once that is achieved, again you can plan IOL accordingly. But in advanced keratoconus, it's always better to go for a triple procedure, that is keratoplasty with cataract, or you can plan surgery. The keratometry that you should take is standard K, that is 43.5, instead of taking the keratometry of the patient. Before I conclude, this is a patient who has referred to me with a vision of 6/18, right? And the diagnosis was the patient is having cataract, so that could be the cause. But when I examine the patient, you see he has all the features of Bardet-Biedl syndrome with retinitis pigmentosa or stubby fingers. So remember, all the cases of keratoconus or corneal ectasia, the poor vision is not because of your corneal opacity. There may be some associated condition. So do a thorough workup and then plan for cataract surgery. With this, I'll conclude here. Thank you very much.
Thank you, Dr. Prafula, for the wonderful presentation and very important tips when you are dealing with the corneal ectasia and the cataract surgery. So our next speaker is Dr. Mohan Rajan, and Dr. Mohan is going to speak on after PCR, what next?
Thank you, RP, and let me again thank the AOS for this wonderful opportunity of being here. It's always a pleasure to coming back to see. Anticipate PCR when you have traumatic cataract, cataract post-vitrectomy, posterior polar cataract, hard-bound cataract, pseudo-exfoliation, and nowadays we have patients who have got multiple injections into the vitreous cavity. We have to anticipate PCR. It's called touch cataract. So stages at which the PCR can occur, any stage for matter, but more commonly during the what you call the cortex removal, because a high vacuum is used and the posterior capsule is not protected as well. So complications, suppose you don't use treat the PCR properly, you can have endophthalmitis, you can have secondary glaucoma, you can have a corneal decompensation, all these problems can occur, and you don't want to have that. One of the most important things is when you have a PCR, okay, see this, what is happening. So when you have a PCR, you get jittery, you may be operating on a VIP or a doctor. So what is important is not to pull out of the eye. Do not pull out of the eye. If you pull out of the eye, what will happen is, what is a small PCR will become a huge PCR, and vitreous is like a tsunami, and the entire vitreous will start coming into the anterior chamber, and you will have a thing. So immediately you need to go bimanual, remove the vitreous first, and then remove the cortex. And what happens to the nucleus? If you have done a lot of karma, the nucleus will come up. Okay, and I have done a lot of karma. You can see how the nucleus will beautifully come up, and that is the way. And normally, when the nucleus goes in, you need to go in, clean up the anterior segment, and do the pars plana vitrectomy as well. And this is a post-operative patient. If you understand this slide very good, this animation, and that is the entire ball game is over as far as PCR is concerned. When you have PCR, you have a coaxial irrigation aspiration. Coaxial means the irrigation aspiration are in the same port, and if you do that, what will happen is the PCR will become more, the vitreous will get hydrated, and more vitreous will come into the anterior chamber and enlarge the PCR. But you have biaxial or bimanual, wherein the irrigation is separated from the aspiration. So you can see this in this particular video here. What I am trying to say is, this is one of the very hard cataracts, and as I am taking the last piece, there is a post-occlusion surge, because I was using a second generation Phacoemulsification at that time, but I didn't lose my calm at that time. I just removed, and I introduced viscoat. The viscoat actually, I don't have any financial interest. The Alcon guys are not paying me a single paisa, but what I am trying to say is, the viscoat goes and plugs that PC tear. Can you see that PC tear is like a small posterior capsular excess? So introduce viscoat, don't allow the chamber to shallow, and gently withdraw the phaco handpiece from the eye. Then immediately create a right side port. When you create a right side port, what will happen is, you create a bimanual compartment. That is, the irrigation is separated from the aspiration, and then you can see that even at the end of it, the beginning as well as the end of it, the PCR size is being maintained very well. Again, during the hydro, it's very important that every time you do a hydro dissection, okay, you need to decompress the nucleus. Why you need to decompress the nucleus? Because you don't want that fluid to go behind and create a what is called a hydro rupture. So this is what happened. You can see here, as I didn't decompress the nucleus. You saw that video, how it opened up the anterior capsule. This capsule is likely to extend across the equator and go into the posterior capsule, and as soon as you put the phaco probe, you can use the thing into the vitreous cavity as well, nucleus. So you can see this is a posterior polar cataract. You can see that as I am trying to aspirate the epinucleus with the phaco probe, I got the PCR. Immediately I injected viscoat, and immediately I put tricot, because I know there is vitreous there. Because if you put tricot, diluted tricot, dilute into 1:3, then you will know exactly how much of vitreous is there, and then go ahead and remove the vitreous first. Don't be in a hurry to remove the cortex and the epinucleus, and that is what you can see here, removing the vitreous and then removing the cortex, and go ahead and put a lens in the sulcus. And you can see again another patient with the PCR. You can see that the PC tear is actually, if you notice very carefully there, it is all the way going. If it is a small PC tear, what is the most important thing is to convert this into a posterior capsular excess, because a posterior capsular excess definitely has got a better strength than a PC tear. This unfortunately was extending from, and it became a radial tear extending into the equator. I was not able to do it, but I was able to maintain that and prevent the vitreous from coming out. But you can see I am putting a single piece Acrisoft lens into the sulcus. You can see what is happening to the PC tear. The entire PC tear starts extending. Fortunately for me, the lens was stable and the patient doing very well. Again, you can see the posterior polar cataract is again a very major issue, and you can see in this particular case how this posterior polar cataract, and this patient is actually an ophthalmologist. He came to me, and he had a posterior polar cataract and was getting scared to get operated. So what happened was, you can see that this posterior polar cataract as I'm doing the posterior polar cataract, as I'm removing the epinucleus, all the slow motion parameters are very, very important. As I'm removing the epinucleus, you can see there is a huge dehiscence. Okay, this is not actually a PC tear, it's actually a dehiscence in the PC, in PPC, and you can see that there is like 2 pillars on the posterior capsule. So immediately I go and immediately I create a right side port, immediately I put tricot, because even with the vitreous is a colorless substance, even God cannot see the vitreous without the tricot there. So it's important that you use tricot there. Don't use too much of tricot because it will go inside and produce a white glow and you may not be very sick. You just use a little amount of tricot, dilute it very well, and that is good enough for you to remove the vitreous. So go bimanual again. But when you put the lens, this multi-piece lens, because there is a huge what you call dehiscence in the posterior capsule, the multi-piece lens, this is an acris of 3-piece lens. Don't leave it in the sulcus. If you leave it in the sulcus, what will happen is there can be long-term decentration, UGS syndrome, secondary glaucoma, all these problems can occur, uveitis. So always lock that optic, that is haptic is in the sulcus, lock that optic into the capsular excess margin. So the lens gets locked, the lens actually, the optic is actually in the bag. You can see this, the end point is the ovalization of the anterior capsular excess margin or the capsular excess margin at the end point. So this lens will be locked forever, and you can see that it's important that because this lens will not move a micron, and you can see that if you have a what you call a posterior polar cataract, mature cataract in one eye, you can always look at the fellow eye. Look at the fellow eye because you do not know whether it's a posterior polar. If a fellow eye has got a AC IOL or a PC IOL in the sulcus or a glued IOL or iris claw, this should give a suspicion. Just to show you, I will quickly go through this. This is the posterior polar cataract and young fellow. This is a mature cataract. The fellow eye had a lens in the sulcus which we missed. So probably we thought, okay, we will go to the femto and went ahead with the femto surgery. You can see there is a huge dehiscence there. I immediately went bimanual and created a bimanual, and fortunately for me, the vitreous face was intact. But I was a little overzealous and went ahead. You can see what I am trying to do. I ruptured the anterior hyaloid there. Once you rupture the anterior hyaloid, you need to make sure that vitreous is removed. This is the postoperative pictures once the lens is locked. And again, since we are running short of time, I will close here. Thank you again for the wonderful opportunity. The most important thing I want to leave home with your message is the final slide which I want to give you. These are the IOL options: prevention, early recognition, good vitrectomy, bimanual techniques, small PCR convert to PCC, do not pull out, use tricot preservative free, bimanual, no using sponges or devakers, remove the vitreous first, remove the cortex and epinucleus, appropriate IOL, suture the wounds, because the incidence of endophthalmitis goes up when you have vitreous loss up to 4 to 5 times. Thank you very much for the wonderful opportunity.
Thank you, sir. I think that good karma part was missing in that take-home message.
Thank you. Good karma.
Thank you, Dr. Mohan, for
good
the
karma is very important.
wonderful description of the PCR and its management in different situations. You have shown beautifully all the cases.
Thank
so
you.
beautiful videos, sir.
Thank you.
Thank you very much.
Thank
and now our next speaker is Dr. Anurag Mishra. You all know him, very proficient cataract surgeon, and deals with a lot of complications and new technology. So today he's going to talk about the low IOP surgery, the standard of care in phaco-cataract surgery. Dr. Anurag.
Thank you so much, sir. Good afternoon, ladies and gentlemen. Greetings and regards from the land of Lord Jagannath. Now, when we switch to the more physiological part of the IOP when we are doing phacoemulsification procedures, we have to remember is, since we are scaling the IOP so low, there's less amount of fluid flowing in. So the only way that we can bring about a successful procedure out of the whole thing is to play around with the other facets of the fluidics. Now, this is a fluidic screen of a phaco machine. As you can see, it has IOP in one point, but keeping the IOP low would necessitate a change in the other two important parameters called the vacuum and the aspiration flow rate. Now, as surgeons, when we handle cataracts, even if we are setting the vacuum at 600 plus or 700, there'll be hardly any moment when we would be using that much of vacuum. So I always try to manage with the less vacuum and less aspiration flow rate. There are a few other changes, things that you can change in vacuum rise, IOP ramp, and irrigation factor. The irrigation factor is a leakage compensation. The IOP ramp is the unit time for you asking the machine to reach the preset IOP at a particular unit time. The vacuum rise is something that I would just like to stress upon. When I handle very hard cataracts, I keep the vacuum rise on negative side, so it slows down the pump and gives me that liberty to hold on to the nucleus that extra bit longer, which helps me in chopping. Now, this is my parameter for a grade 2 cataract. I always operate under an IOP of 20. It never ever goes down beyond that. The vacuum I keep is 450 panel, and the aspiration flow rate is just at 23. For a grade 3 or a grade 4 plus cataract, the only thing that will change in these settings is the vacuum, which would be scaled up to 500, will be kept in the panel mode, but will be scaled up to the 500 instead of 450, and the flow rate would go up to 26 instead of 23. Now, a lot of us do not know about this. You can also manually select how much of leakage compensation you want. Say inadvertently you have made a larger side port than you intended to initially, go back in the setting of the machine and change the estimated leakage compensation that you want. This is there in the setting of the machine. It's kept at 0. It's always kept at 0 for me. But then when I see that inadvertently I have created a larger side port, you can keep it at 20 or 10, so that manually also there's more amount of fluid going in, hardly altering the IOP. So why the shift happened in my case was not because I'm very fancied and doing fun things. It's just that I wanted to avoid the potential injury to corneal tissue and all the other elastic structures that are present around, post-operative inflammation, reduced blood flow to the chorioretinal vasculature, NAION and the possibilities of it, and increased vascular density and CME. All this is theoretical. What comes out to the practical point is something entirely different, might be something entirely different. So I'll just present a spectrum of 3 quick surgeries. This is one such compendium wherein the pupil was small, the patient was highly aged, the endothelial status is not great, and you can look at the cataract, it's looking all black. IOP is at 20, the aspiration flow rate is kept at 24, and the vacuum set at 500 panel. So in these cases, we know that we're not allowed to go to the periphery. We're not allowed to do a particular defined horizontal chopping. We have to stay in the pupillary plane, beyond the capsular margin. All that is imaginative is fine, but still, the fluidics of the machine is this is an unedited video. I've not edited any portions. It's just been sped up in the interest of time. But as you can see, we are standing at a CDE of 7.3, and we have already started emulsifying the pieces. A good idea about to implement in such kind of hard cataracts is chip and flip. I mean, crack, divide, and eat it away immediately, leaving behind the other part of the nucleus still inside the bag. What it does is it gives you the liberty of extra space in the bag, and at the same time, it also reduces on the energy front. I'll be very happy if I conclude this particular case under a CD of 30, which I would eventually be doing, and the fluid that I consume in the process would be staying in somewhere around 45 to 50 cc. That's my threshold. If I go beyond that in fluid usage, I always look at the patient more carefully in the post-operative period, because apart from the energy, the fluid turbulence and the fluid hit also is something that causes damage to the corneal endothelium. The second case would be a very deeply set eye. So the highlight of this particular surgery would be, we know that when the eye is deeply set and you are doing phacoemulsification, there is a pool of fluid that gets collected on the surface, and you have to see through that pool of fluid, so the visibility gets marred. Not so if you're using low fluidics. So very minimal amount of fluid goes into the eye, and the visibility is not marred. In the later part of the surgery, when it comes to IOL implantation, I always do a hydroimplantation or a BS-assisted implantation of the IOL, and in that situation, I raise the IOP to around 55. You will see the change then. This is perfectly visible. There's no problem with the eye, and there's no problem to find out the cleavage planes. Once again, this is an unedited video, just been sped up. So the bag has been cleared with the nuclear pieces, and the visibility is fine. When we go to the IOL implantation next and the IOP increases, look at the fluid now. It creates a sheen there, a reflex there. Through that, it might be difficult to do a phacoemulsification. However, implanting the IOL is much easier than doing a phaco procedure, so you just have to know the plane at which you have to dial it in. So that's just one such area where the low IOP also helps us. A posterior polar cataract, we all know the basics. The IOP stays at 23, the flow rate stays at 23, and the vacuum stays at 450. This is, don't get fooled by the brilliant appearance of the red glow. This is my microscope giving it, but this nucleus is also pretty hard to the tune of around grade 3. So when you start emulsifying this, you would notice that these are the circumstances wherein you don't want anything to push from the posterior side. You also don't want anything to push from the anterior side. So the fluidics should stay stable and low. So this is my technique of handling the polar cataracts. I always carve out 2 pies at the distal end without rotating the nucleus at all. And then I remove those 2 pies so that it gives me extra space. And now from Dr. Titial's study, we know that this also does complete the hydrodelamination, and then it facilitates the movement of the nucleus inside the bag. So after those 2 pies are removed, then the left-hand side pie is then taken, laterally chopped, and then levitated out of the bag with the second instrument, and then it is emulsified. And in all these steps, if there are fluctuations in the AC, you would be worried, you would be concerned. There are no fluctuations in the AC because we have handled the other facets of the fluidics. We have kept the flow rate low, we have kept the vacuum reasonably low, and in this particular situation, you can see a dip towards the fag end of foot switch position 2 in the vacuum. So from 450, it comes back to a threshold of 0, downsloping, so that when you are losing vacuum, there's no surge. So we are done with the nucleus. The CD count is pretty acceptable now, and then the rest of the epinucleus in the cortex can be stripped off just in the routine way that we have all been exposed. In such short time, this is all I could muster. Thank you so much for the opportunity and the attention. Sign off.
Beautiful, beautiful presentation, Anurag. I think you have mastered the Centurion mission so very well in the active fluidics. We go on to...
I did not name the machine, sir.
It doesn't matter. I know it's a Centurion because I'm also using it. But we go on to Dr. RP, Dr. Rajendra Prasad, and he's got a very, very busy practice, the RP Eye Hospital in Delhi, and he's going to talk to us on a very, very important topic. While, what exactly is the topic?
It's while chopping, when the cataract doesn't crack, what to do.
Yes.
So
Yeah,
thank
you
you.
better tell that, yes.
Thank you, Dr. Mohan Rajan, for the nice introduction. The topic which I'm going to talk about is the while chopping, when the cataract doesn't crack, what to do. You all know though that the chopping techniques are basically a mechanical, manual manipulation of the nucleus to get the fracture of the nucleus. And we have a variety of ways to do that manual manipulation within the capsular bag to fracture the nucleus. But when it comes to these very hard and the rock hard cataract in our clinical practice, many a times we do not get the complete fragmentation or the cracking of the nucleus. And you all know that if you don't get the crack in the nucleus, if you don't get the free segmentation of the nucleus, then the whole problem starts, and we start struggling to take out these pieces with the phaco probe. These conjoined segments, they don't come out of the capsular bag, and then the emulsification procedure becomes very prolonged and manipulations become very long, and many of these problems may come up. And then we normally switch over to these hybrid techniques, and you know that these hybrid technique, you have to use a lot of phaco energy, a lot of manipulation. You try to trench at the center, make a large groove, cross the groove or the single groove, and even then, many times you don't get the complete segmentation. And with this, the problem of the CD value comes up when you are dealing with these hard cataract. And as Dr. Mohan Rajan has shown in the morning, like you had a brown cataract and the white cornea on the next day. So that is the problem we come across many a times. And then what should we do in this situation to deal with this kind of cataract? So what we need to do is either we have to strengthen our manual fracture forces, we may have to change the chopper, we may have to change the direction of the manual cracking forces, and also we may have to change the phaco settings. So before we start anything to do out of these things, we must be sure that the pupil is well dilated. If not, then you can put in the intracameral injection of phenocane or these dilators. We may use the expanders, as Dr. Mohanta has shown, the BHACs or any other dilator or the expanders. And we must inflate the anterior chamber with maximally retentive viscoelastic so that you have a good anterior chamber. And if possible, increase the size of the rhexis, because the small rhexis, it's very difficult to deal with these hard and rock hard cataract. But the most important point in this situation is to change the direction of the fracture forces. How to change? So to change the direction of the fracture forces. And what we normally do with the vertical chop and the horizontal chop, we try to crack the nucleus at the center, which is the thickest and very heaviest part of the nucleus, and it becomes very difficult to crack. So why not to crack the nucleus from the equator itself? So I'm going to show you this video, a small video you can see here. So what we need to do is just hold the nucleus and draw it a bit, hook it around. So you can see the device which is going all around the nucleus, and you get a fracture. Now this technique can be applied on any type of the cataract, starting from the grade 2 to grade 3 nucleus. And you can see here this a white cataract, but very calcified and white cataract, go around and you get a complete fracture. And this fracture of the nucleus, as you can see, it starts from the equator, it goes to the center and the equator on the other side. So you get a complete segmentation of the nucleus in 2 fragments. And this is a little harder cataract. You see the kind of fragmentation you get. You get a complete fragmentation without leaving the posterior plate. And if you get a complete fragmentation, your rest of the steps becomes very easy. So this is a bit harder cataract, grade 4, and this is the grade 5 nucleus. And you can see you have to hold it, start the impaling nucleus from the center and draw it a bit. You see the edge. The best part is you are seeing the edge of the nucleus and then you are hooking. So there is no threat to the anterior or the posterior capsule, and you get a complete fracture. This is the grade 6 nucleus. You just go from the center, impale, hold the nucleus just within the equator of the nucleus and draw it, see the equator and hook it, and then you get a complete fracture of the nucleus. You have to do a very little lateral manipulation. You don't have to put too much of forces to separate the nucleus. You get automatically the segmentation of the nucleus from the equator itself, and then this is the fracture. And a brown nucleus, a hard brown nucleus, you get a kind of fracture you get. So in any grade of the nucleus, because this hard cataract, it becomes so easy to fracture these nuclei, because if you get a complete fracture, then you can draw the fragments and start emulsification as you wish to. Now this is the grade 6 nucleus. As you can see, the grade 6 dark brown or the black nucleus also. You go around, get a fracture. See the complete fracture. Even the posterior pole, you can see the posterior plate of the nucleus is also fractured. And once you fracture the nucleus into 2 heminuclei, then take the first heminuclei, make further segmentation. You can make 2, 3, 4 segments, and then you start the emulsification of these free segments, because once the segments are free, you can draw them very easily out of the capsular bag and start emulsification. What you can see here is the kind of fragmentation what you get, as if you have cut the nucleus, because this is a cracking of the nucleus. You are not cutting the nucleus with the chopper. It's just a crack of the nucleus what you get. And then you can complete the emulsification of the rest of the segments. So to do this technique, you need a very important device, that is the chopper, because your chopper has to be correct, and this is the chopper which we have created. And as you can see, this is the wedge device which has been incorporated within the inner edge of the chopper. And once you incorporate this, now this becomes a wedge device. Now this has a wedge inner edge. You can see the wedge inner edge. Now this wedge inner edge is the most important. And look at the tip of the chopper, it's a blunt and olive tip. So when you are hooking the nucleus, it won't threaten the posterior capsule. It's not a sharp chopper, it's a wedge chopper. And how do we use this chopper? You can see here in this animation video. This is the phaco probe, which is impaled from the center, and you are going towards the equator. You don't have to go into the equator, just 2 millimeters within the equator. And this is the chopper which is coming up. You have to hold the nucleus, draw it a bit, and hook it around. See, this hooking is very important, because you are hooking it through and through of the nucleus, all around the nucleus. And then once you draw it, you get a crack. You can see here, this wedge will create a crack in the nucleus at the equator, and you don't have to struggle much. The nucleus segments into 2 fragments completely, and then you can go in for the further segmentation of the nucleus into 4 or 6 pieces. So this is the technique which is called as a terminal chop. This is the publication. And to conclude, this is extremely simple technique, because unlike horizontal and vertical chop, which is quite complex for the beginners, it's very simple, very highly efficient, and least traumatic. You don't have to put too much of mechanical forces. It's a simple cracking of the nucleus, least stress on the zonules and the posterior capsule, and you get a crystal clear cornea because you're not using too much of the phaco forces. And to draw these nuclei and segment these nuclei, you get a crystal clear cornea on the second day itself. So a clear cornea on the second day in these hard cataract instead of getting a white cornea. Thank you very much.
Thank you, sir, for that wonderful demonstration of terminal chopping. Next, we have Dr. Kavita Powell with us. Ma'am is going to tell us about one of the most difficult aspect of pediatric cataract surgery, how to work up a case of pediatric cataract.
My presentation. Good afternoon, everybody. After lunch, I think everybody must be feeling sleepy. Let's go ahead with our topic. I thank Dr. Namrata for giving me opportunity to speak over here and the AIS midterm conference. Thank you. My topic is workup of a case of pediatric cataract. Evaluation of pediatric cataract requires a coordinated team effort involving ophthalmologists, pediatrician, anesthetist, orthopticians, counselors, and parents. Family history of any systemic disease, antenatal history of rash, febrile illness, drug intake, and X-ray exposure is must. You have to take the natal history and the history of child growth and development, feeding and digestive behavior. Physical examination by pediatrician, you have to, it can be associated with myriad of systemic conditions like chromosomal anomalies, craniofacial, mandibulofacial, skeletal syndromes, metabolic disorders, congenital infection, dermatologic, CNS, musculoskeletal, and renal disease. Now, visual acuity estimation as per age is a very essential thing. First, the most important thing is the red reflex or the illumination test, which is to be done in the pediatric case. It should be done in an undilated pupil to assess the, estimate the visual significance of the opacity. Any central opacity or the surrounding cortical distortion of more than 3 mm in diameter is visually significant. Now, in the picture you are seeing the top, can I have a pointer? In the picture you can see there is a anterior capsular opacification. Now, usually the anterior capsular opacities are not visually significant, but only if it is acquiring more than 3 mm in diameter, occluding entire pupil like this, which is the anterior pyramidal cataract, it needs to be operated. Most of the time it does not require any surgery. Now, this is a case of posterior sutural cataract, which is a Nance-Horan syndrome. Usually females carriers have this kind of cataract, but usually if the opacity is not having a very good, when you are doing retinoscopy, if lot of area you are getting red reflex and it is not hampering the visual axis, then you need not go for the surgery. This is the posterior lenticular opacity, requires surgery. Now, here you see this is an anterior lenticonus. When you see the lens morphology, this is the anterior lenticonus, and anterior lenticonus is associated with Alport syndrome, and this you can see a posterior lenticonus. Posterior lenticonus is, it progresses with time, and at times what happens, gradually the patient might get an acquired cataract, but usually it also does not require surgery unless and until sometime it develops tear, and in that case total lenticular opacity appears and you require to get it operated. These are the various morphologies, and you can have different type of cataract like Christmas tree, rosettes, purulent cataract, and at times you can get green flecks and Wilson's disease. Traumatic cataract needs to be operated, you have to evaluate everything. Now, lens position, it can be a superiotemporal or inferior nasal subluxation, and it can be a spirophakia in Weil-Marchesani syndrome. Then you have to look for the lens position also. While evaluating the posterior segment, it's important to do a B scan to rule out any persistent hyperplastic primary vitreous, any retinal tumors, or any retinal detachment. Any associated strabismus, usually unilateral cataracts are associated with strabismus, which is suggestive that already the time of surgery is gone, but still you have to go ahead with the surgery. Any bilateral cataract will be associated with nystagmus, that is also suggestive that the time is gone, but you have to go ahead with the surgery. Now, systemic evaluation investigation, especially done in those children where infective etiology such as rubella or metabolic disorders such as galactosemia or syndromes are suspected. A tailor-made investigation is offered in torch, hypoparathyroidism, hypoglycemia, galactosemia, syphilis, Alport's, homocystinuria, etc. Investigation to be done are IgG, IgM titers, blood sugars for diabetes, galactose 1-phosphate levels for galactosemia, VDRL, and urine protein for homocysteine, and urine amino acid and copper levels, and serum calcium and phosphorus for hypoparathyroidism. Now, evaluation under general anesthesia, it's a standardized protocol for every patient. A full team of ophthalmologists, anesthetists, pediatrician, technicians, and supporting staff need to be present during evaluation. Laryngeal anesthesia is preferred. In selected older children, you can go under ketamine also. IOP measurement is done following induction of anesthesia. The first procedure is applanation tonometry performed using Perkins handheld tonometer. Keratometry is performed by an experienced examiner and an average of 3 or more reading are to be considered. Axial length measurement is performed using immersion ultrasound and an average of 3 or more good readings is considered. Corneal diameter, both horizontal and vertical corneal diameters are measured using operating microscope using a caliper which measures in steps of 0.5 millimeter. Slit lamp examination to look for the corneal clarity, the anterior chamber depth, anterior and posterior synechia, iris configuration, lens morphology and position. One of the most important thing is you should document everything by video recording or clinical photographs. Gonioscopy is performed using a slit lamp attachment of a microscope. Angle structures visible, the degree of pigmentation, any angle anomalies are noted. Detection of any angle anomaly has a prognostic significance in development of glaucoma. Now, in the end, the dilated retinoscopy is performed by a trained, experienced optometrist. Thus, a detailed evaluation helps us to better plan the surgical strategies and give the prognosis to the parents. Thank you.
Yeah, very beautifully covered, Kavita. Very nicely covered about what are the things you should do in a pediatric cataract. And we go on to Dr. Amit Porwal, awarding Tsunami in mature intumescent cataracts.
So thank you. Can we have the mic, please? Yeah. So thank you, Dr. Mohan and the chair for inviting me for this talk. So I'm going to talk about how to avoid the tsunami in mature intumescent cataract. And what do you mean by tsunami? Tsunami is basically prevention of the Argentinian flag sign, which most of us encounter when we are doing cataract surgery in mature intumescent cataract. So what are these intumescent cataracts? They are basically swollen, congested, there's a hydration of the lens matter, and there's increased intraventricular pressure. And because of this increased intraventricular pressure, the capsule is more stretched, the anterior capsule become more convex, and what happens after that? The visibility of the capsule is hampered. We have to stain the anterior capsule. It is very, very important because if you don't stain it, the elasticity of the capsule is so high that, and the convex anterior capsule will just give away. And what is this tsunami? The moment you puncture the anterior capsule, suddenly the capsule gives away in both sides, and because it's a stained capsule, it looks like an Argentinian flag, and that's why it's called an Argentinian flag sign. So this is very, very important. How do we avoid this complication, or how do we avoid the occurrence of this Argentinian flag sign in mature intumescent cataract? As we all know that CCC is an essential step in performing a phaco surgery, and when you have an extended CC, your phaco surgery becomes more complicated. So just sharing a technique which I am following, and I've been presenting and published this technique. So you can see this is a intumescent mature cataract with a stretched anterior capsule which is more convex. So staining of the anterior capsule is done, and you have to make sure that the entire anterior capsule is stained properly. Once the staining is done, why it is important? Because the trypan blue dye reduces the elasticity of the anterior capsule and it makes the capsule more rigid. Now with the 2 cc needle, a 2 cc syringe on a 24 gauge needle, you just bend it like an L shape, enter into the center of the anterior capsule, stay there, remain steady, should not have any hand movements, and try to aspirate it. You can see the moment I am aspirating, the central part of the anterior capsule is becoming concave now. Why is that so? Because we have decreased the intraventricular pressure, and this is the cut you get. Now if you are not steady, this cut will extend. So you have to be very steady. and again reform the anterior chamber wherever needed. Reforming the anterior chamber doesn't mean go on overfilling the anterior chamber with a cohesive viscoelastic substance. It should be adequate so that the anterior capsule becomes flat. Now there are different techniques. I usually use a capsulotomy needle, but you should be able to do the rhexis with the help of a capsulotomy needle, a rhexis forceps, through the right hand, through the left hand. You have to be versatile. So in this case, you saw initial nick it was given, and then I started with the small rhexis. Always it is better to do a small rhexis. Once you have better control of the anterior capsular flap, then you can extend the rhexis like a spring onion type of the snail ring pattern type of the rhexis. You can see I started with the small rhexis. Now I've gone beyond the initial point, and I'm trying to peel off like the skin of the onion. So this is a this is a snail pattern rhexis. Throughout, you make sure that the anterior capsule is flat. It is always advisable to make sure that you use a cohesive viscoelastic substance. Never have large tears, have small tears, and have a controlled movement whenever you are doing these rhexis. So you can see you have decreased the intraventricular pressure and how you get a well-centered rhexis. Sometimes you get a decentered rhexis. Nothing to worry after you have implanted the IOL. With the help of a micro 1 forceps, always give a tangential cut, never give a radial cut. And with the help of a micro rhexis forceps, you can just refashion the rhexis to the desired size and shape what you want. So if you are comfortable in doing a phacoemulsification, even in a small rhexis or a decentered rhexis, don't worry about it. You can refashion the rhexis after you have implanted the IOL, and you can get a good optic coverage of the anterior capsule throughout. Again, that's what I was trying to tell you. You should be able to use right hand, left hand, a capsulotomy needle, a micro rhexis forceps, and a micro 1 forceps is must in your cataract tree. One more case I am showing you, also you can see how intumescent this cataract is, how stretched the anterior capsule is. Staining of the capsule has been done. You can see I am injecting I am piercing the anterior capsule with a 24 gauge needle mounted on a 2 cc syringe. We had done a study in which we used a 1 ml syringe, we have used 5 ml syringe, we have used a 26 gauge needle, we have used a 30 gauge needle. But what I found was 24 gauge is adequate because sometimes the fluid is turbid, so it doesn't get aspirated. So you saw when the moment it got aspirated, it's concave in the center, but you can see in the mid periphery, the slight bulge is there. So now when you are fashioning your rhexis, you have to make sure that you are at the highest point or within the highest point. If you just go beyond the highest point, this will give away and there will be an extension of the rhexis. So you have to make sure you are within this, within the highest point, that the mid periphery what is there, and try to perform the rhexis. You saw I was doing the rhexis from the left hand through the side port because my initial nick was not in a proper direction. I didn't go through the main tunnel. So you have to make sure that at what particular time, which side port you are going to use, what instrument you are going to use. Throughout the whole capsular rhexis, give some extra time when you are performing the rhexis. Always make sure that you use a cohesive viscoelastic substance. Never go for an HPMC. Another technique to reduce the intraventricular pressure is basically you can do a YAG anterior laser capsulotomy. You saw I gave one shot of 1.2 millijoules right in the center of the anterior capsule, and there is a gush of liquefied cortex which is occurring. You can see like a waterfall, it goes on coming. So you do this procedure in your OPD, then shift the patient to the OR. By the time the patient is in the OR, he is lying down, the whole cortex has come down, the intraventricular pressure is decreased, and then your surgery becomes comfortable. So this is another use of this YAG capsulotomy laser what we have. We can use this in mature intumescent cataract, but make sure you give only one shot in the center. What happens when you give the one shot in the center? You get a stellate opening. You can see the stellate opening after I stained the anterior capsule, after I have done the YAG laser capsulotomy, there is a stellate opening, and then you can continue with the rhexis. We have done this study. We have calculated the pre-YAG ASOCT and the post-YAG ASOCT, and definite increase in the ASOCT in the anterior chamber dimensions is there. It has been published as a role of preoperative ND-YAG laser capsulotomy in mature intumescent cataract, and was also featured in the AO Academic Express of the Asia Pacific region. I also won the best physical poster award wherein decompressing mature intumescent cataract. Various techniques were compared in which the YAG laser was done, in which double rhexis was done, needle aspiration was done. So we have compared lot of multiple parameters, and we had presented this. So the best tip to avoid a tsunami in mature intumescent cataract is to decrease the intraventricular pressure. At any cost, you have to decrease the intraventricular pressure, and how can you do it? You can do with the ND-YAG laser anterior capsulotomy or through a slow and cardiac decompression of this raised intraventricular pressure. So thank you, and thank you for the time allotted.
Thank you, sir, for that wonderful talk. Now, I would like to invite our next speaker, Dr. Parul Singh. If your eye will get decentered, then the patient is going to give you a lot of trouble. So prevention always better than cure. So ma'am is going to speak about what intra steps you can take to prevent post-op decentration?
Thank you so much, sir. A very good afternoon to all the people on the chair and the hall, and I really thank AIOS for this wonderful opportunity to be in this beautiful city of Visakhapatnam. So I'll be speaking on intraoperative techniques to prevent post-operative decentration in regular phaco. We all know that proper centration of IOL is really very important, and we get clinically insignificant decentration in at least 25% of the cases, which we can go away with, but clinical significant decentration occurs in about 3% of the cases, and these are the cases that have to be dealt with care and we should avoid. So the common presenting complaints in a decentered IOL, the first one is vision. A gross loss of vision can occur due to gross decentration and dislocation, but a diminution of vision can occur in a decentered IOL due to astigmatism and the various aberrations that may happen. Loss of contrast also adds to diminution of vision in a great deal. Now the second common presenting complaint is of that photopsia. The decentered IOL gives patient negative experiences of glare, halos, ghost images, double images, and lot of photosensitivity. So the causes to understand why we get a decentered IOL, which can be preoperative causes or the operative causes. So the preoperative causes can be a subluxated cataract when we have zonulopia, or in all the cases of pseudoexfoliation, high myopes, elderly people when we deal with large hard nucleuses, or if the capsular bag is either too large or too small. A wrong size of IOL also causes a decentered IOL sometimes. The traumatic cataract we deal with, often leading to complications, may lead to a decentered IOL. Posterior polar cataracts, as we all know, that difficult cataracts, so sometimes when we encounter certain complications, they'll end up in a decentered IOL. And the vitrectomized eyes and the silicone-filled eyes are often the causes of a decentered IOL. Now the operative causes which leads to a decentered IOL, the first is the decentered capsular rhexis. So when a rhexis is not central, often it leads us to a decentered IOL. A too small or a too large CCC leads to a decentered IOL. A posterior capsular tear, which leading to, if a vitreous tag or if leading to a sulcus fixation of IOL, is also an important cause of a decentered IOL. Any zonular dehiscence, either anterior zonules, posterior, or a total zonular dehiscence is a very important cause, we all know, of a decentered IOL. While putting up an IOL, sometimes the haptics get broken or they remain bent. A broken haptic is often a reason for a decentered IOL, which if we do not take care and we just let it go there, it leads to a decentered IOL and all those complications which happen, patient experiences. A wrong placement of IOL sometimes would also lead to a decentered IOL. As we all know that with increasing use of these aspheric and premium IOLs in today's surgery done by all able hands today, and there is loss of contrast, and which leads to decreased effectivity already. So with all these IOLs, if the glare halos of a decentered IOL add up, it causes a lot of problem to the patient. So it is our responsibility when we use these premium IOLs so that we have a very centered and good IOL. As the longevity has increased of the patient, so we need a IOL well centered for the longest period of time. So dealing few cases in which we have a decentered capsular rhexis, if you see in this case, the rhexis is not a central one. So we should, after planting the IOL, we should just not leave it like that. What we can do is, in the last video shown by Dr. Purval sir, he also mentioned it. So what we are doing is, after placing the IOL, with this microforceps, what we are trying to do is, we are trying to give a nick in the anterior capsule, and with the help of these microforceps, we are making this rhexis central. So by little effort, what we can do is, we are really making the difference in the outcome of the surgery. So this way we can make this rhexis central and not let it go as a paracentral rhexis. This is the second video in which this is a case of pseudoexfoliation, and if you see closely that the rhexis has not started from the center. So this rhexis had since not started from the center, so we can expect that at the end of the completion of the rhexis, this rhexis would most probably not remain a central rhexis. So what we can do here is, we can, as soon as we realize that we did not start the rhexis from the central point, as soon as we realize, we can come back to the center, give a nick, and then make an effort to get it back to the center, so that now we can, even when we started our paracentral, but we can again go to the center and end up having a central rhexis. In this case only, in this pseudo exfoliation case only, after we have done this rhexis central, since it's a case of pseudo exfoliation and we do expect a lot of bag dehiscence, so what we are doing is, before placing the IOL, we have put a CTR ring beforehand, in this anticipation that it might be an unstable bag and we do not want an unstable bag with an unstable IOL. So after we do the complete surgery, before we plant the IOL, we have planted a CTR ring, and this CTR ring will lead into a stable bag, and we will have a beautifully scented IOL even in the case of a pseudo exfoliation. The next video is a video in which, if you see, when we are doing this irrigation aspiration, you can see that we are having a lot of flip and flitter on the anterior capsule. So this flutter in the anterior capsule, which is visible here, if you can see closely, this flutter tells us that the anterior zonules are weak. So in this case, again, to prevent the decentered IOL because of the anterior zonular weakness, what we can do is, you can see very clearly how decentered the IOL will look because of this anterior zonular weakness causing unstable bag. What we can do is, we can plant a CTR ring, and this CTR placement will end up into a very well stable bag taking care of the zonular weakness, and we'll have a centered IOL. The next case is of a zonular dialysis. This, you can see, this is a non-dilated pupil and a very hypermature cataract. So we have to be very, very cautious. We can expect zonular dialysis as well already. So first we start the surgery by placing the iris hooks so that we can enlarge the pupil. And just a second. So here we put up and we do a rhexis, and in this case, after doing the phaco, you see that we see a zonular dehiscence. So in this case, we would put a CTR before taking out these pieces of cataract to make a stable bag and do not let the bag go away. Very important to put a CTR at this point in this case. Another case is again of a posterior zonular weakness. In this, just a few moments. In this case, you can see while we're doing IF, you can see there are a lot of undulations in the posterior capsule. These undulations in the posterior capsule, they tell us about the posterior zonular weakness. So again, after planting the IOL, after we realize that there is posterior zonular weakness, we can go ahead, put a CTR ring in this case as well, and get a stable bag. Thank you so much. The take-home message is, all attempts should be made to prevent the long-term decentration. Centered rhexis is the key. Take care of zonular weakness and do not hesitate to use the CTR. Thank you so much.
Lovely presentation, Parul. I think it's really fantastic, and you have covered all the aspects of decentered IOLs. I want to know from the audience, since Partha is also there and Prafulla, post-COVID, I find a lot of patients coming with decentered IOLs, subluxated IOLs, dislocated IOLs. Is there any relationship? I'm not very sure whether it's for no reason at all. These patients are all coming. Have you noticed anything like that in your practice? Just last week, a few days back, I operated one, completely done about one-eyed patient, done about 15 years back, and completely the whole IOL bag complex dislocated into the vitreous. So I did a vitrectomy, removed the IOL and put a glued IOL as well. So to prevent decentration, I think is a very important point, which is especially when you have a PCR. When you have PCR, what happens is the pupil becomes small. Always use iris hooks to find out where exactly your sulcus is before you put a lens. That's again very important. Yeah, Partha, quick. Yeah, you can use this mic.
I think it's over the whole country. We have definitely found that it's because of the delay, not so much because of any other reason of COVID itself affecting the eye, but the delay, and the elderly have taken very long time to come to clinics to get their cataract surgeries done. So the delay has been the major factor. and the offending reason as well. But the number of subluxations, etc., what we used to do in pre-COVID in urban areas has definitely greatly increased post-COVID.
And another thing is pseudo exfoliation. What I'm doing now is I'm using I'm following the David Chang's technique. I'm putting a multi-piece lens in the sulcus and capturing that into the bag, because the pseudophacodonosis is much less. Many reports, many papers have also been published on that. But leave it in the bag. The problem is over a period of time the rhexis can start contracting, pull the zonules, and the whole IOL bag complex can dislocate into the vitreous. Professor, your take on this?
Sir, about pseudoexfoliation or that increased incidence of
Generally, both.
Generally, okay. So just on a lighter note, if you go through the different studies published during COVID time, the domestic violence incidence, it went up. That could be one factor for that increased incidence of eye dislocation. Or if surgeries during COVID time, and we at RP Center we have come across a lot of cases when the surgery were performed during COVID, and maybe because of that precautions, that mask, that fogging, the surgeries were not of that quality. And we get a lot of complicated cases, especially those cases that underwent cataract surgery during COVID time. So that's a fact. And second, pseudo exfoliation in RP Center we don't get that many cases, but when I was at LVP, I used to see a lot of cases of pseudo exfoliation, and those are really scary. And there are several techniques, and whatever sir is following, I think that is also a great technique. But I still prefer to insert the IOL in the bag and with a CTR. And if I'm too much scared about the bag condition, I would put an extra CTS along with a CTR.
Any other questions from the audience regarding any other speakers? No questions. Okay, thank you very much.
So we hand over the session to Professor Rohit Saxena, and welcome sir.